Good morning. Thank you to Oxford Nanopore for the invitation to speak here today on this project that I am excited to share with you today about featuring one of my favorite regions of the human genome. This is chromosome 15, specifically 15q11.2q13. So this is the Prader Willi Angelman syndrome critical region. We heard about angelfish genomes a little bit earlier. I'm going to be telling you about Angelman syndrome. So these are two different imprinting disorders that are caused by differences in gene expression. And so this is a region of the genome where we have different expression of genes from the paternally derived chromosome 15 and the maternally derived chromosome 15. So if you can see over here, the genes illustrated in blue are only expressed from the paternal chromosome 15, where the genes in red are only expressed from the maternal chromosome 15. When you have differences in this, it can result in one of these two imprinting disorders. So Prader Willi syndrome is the absence of the paternally expressed genes, whereas Angelman syndrome is the absence of the maternally expressed genes. All right, so for those of you who are not familiar with Prader Willi syndrome, just want to give you a brief breakdown of some of the clinical features that can be seen in individuals with Prader Willi. So it can present prenatally with decreased fetal movements or intrauterine growth restriction. One of the most common indications that we see for testing in my laboratory is this infantile hypotonia, or in lack of movement in these infants. I think the other sort of hallmark unique feature of Prader Willi syndrome is typically appears later on in adolescence with excessive eating that leads to central obesity that can be very challenging for patients and their families to manage. In contrast, Angelman syndrome typically have a normal prenatal and birth history and normal development up through 6 to 12 months of age, and then an acquired microcephaly, so a smaller head circumference that's not present at birth, but as the child grows, the head doesn't grow at the same rate. And some of the hallmark features of Angelman syndrome include a really severe language delay, as well as seizures, and they also can have some unique behavioral findings as well, including like a very happy demeanor, and they can be very excitable kiddos and adults. So the molecular defects in Prader Willi and Angelman syndrome, as I mentioned before, are absence of expression of one set of genes or the other. So for both Prader Willi and Angelman syndrome, the most common molecular defect is a deletion. And so there are segmental duplications within this region of chromosome 15 that give rise to these recurrent deletion sizes. And so if the deletion falls in the paternal chromosome 15, it's Prader Willi syndrome. If the deletion falls on the maternally derived copy of chromosome 15, it will result in an Angelman syndrome phenotype. The other category that I want to mention is uniparental disomy. So this is when you have two copies of a chromosome from one parent. It could be an identical chromosome, or it could be two different chromosome 15s that have been inherited from your mother, giving rise to Prader Willi syndrome, or it's more rare in Angelman syndrome, only about 1 to 2% of cases, but you actually have two copies of the paternally derived chromosome 15. The other categories can include imprinting defects. So this is the failure to reset or establish that methylation pattern. And then in Angelman syndrome, there are actually about 10 to 15% of cases are due to single nucleotide variants or smaller changes within the UBE3A gene itself, and specifically the maternal copy of UBE3A, since the paternal copy of UBE3A is not expressed. And then about 10% of cases, we actually don't know what the molecular defect is in individuals who have a clinical diagnosis of Angelman syndrome. Traditional testing for both of these disorders is quite challenging. I'm not going to walk you through these flow diagrams, but it typically involves methylation analysis, some sort of copy number analysis, which could be a chromosomal microarray, it could be FISH. You might need to do microsatellite analysis to determine the parent of origin of that defect, as well as sequencing. So this can take a lot of time. in my lab, when I first joined in 2016, we were running a methylation PCR assay. So thank you, Billy, for introducing bisulfite sequencing. So this is a really simple assay. It's one of the first ones people will train on in the lab, and we're taking advantage of that different methylation pattern, doing a bisulfite conversion step, and then using 2 sets of primers that will amplify these bands of different sizes. And so let's see, in my normal control, lane 10 on the end, you have these 2 bands, but in our Prader Willi syndrome, we only have the higher maternal band. In Angelman syndrome, we only have the single band. The problem with this assay is that it doesn't provide information on the molecular defect that's underlying this, and that can be really important, both for genotype-phenotype correlations as well as understanding recurrence risk. So back, I think about 5 years ago in my group, we validated an assay with this methylation-sensitive multiplex ligation-dependent probe amplification, or MLPA. It's much more colorful than our methylation PCR assay, and also gives us more information as well. So it's an assay that's performed in duplicate. We have 2 reactions. The top panel is giving you information about the copy number states. This is probes across the region of chromosome 15 in that purple shaded region, some control probes in gray. And then the trick here is that we are including a restriction enzyme that cannot cut the methylated. When it overlaps the restriction site where it's methylated, it's not cut. And so we have 5 probes down at the bottom where you can see a reduction. Those black dots are now lower. And so this is indicating that we have one maternally and one paternally derived copy of this material, and when we include that restriction enzyme, we see this decrease in signal. In the case of an Angelman syndrome deletion that we have on the right, so you can see we have a decrease in the signal, the copy number on that top panel, and then the presence of only the only copy that is present is the paternal unmethylated copy, and so we have no amplification of the probes there. So this works pretty well, but it doesn't give you all of the information, which I'd like to illustrate with this case example. So this is a real patient that we performed testing for in my lab. She was seen at Seattle Children's Hospital. She first presented, I believe, was first seen by the neurologists. And this was in COVID. This was a telemedicine visit, but her parents were concerned because she was 2 years old and she was not walking and she did not have words yet. So the sample that arrived in my lab was a blood sample, 2-year-old female with developmental delays. So here I'm showing you chromosome 15. This is the copy number pattern on the top, as well as our SNP probes on the bottom. And so you see these 3 tracks indicating the presence of both homozygous and heterozygous SNPs. Sign this out, chromosomal microarray, negative, no findings. A few months later, she's seen in person by the neurodevelopmental team and the neurology team. And at this point, they note that she is microcephalic, so she has a smaller head circumference. And she has some behaviors, as well as some severe language delays now that make the team concerned for Angelman syndrome specifically. So they order our MS-MLPA assay. It's negative. So we have a normal copy state, normal methylation pattern. Do sign it out with this disclaimer that this test is pretty good at picking up cases of Prader Willi syndrome, but about 20% of individuals with Angelman syndrome will have alterations that we can't detect. But it gets signed out. The top line of this report says negative. A few months later, she has some additional testing. She is seen in the biochemical genetics clinic because of some abnormal screening labs. And they're talking with the family, do we want to do targeted testing to focus on this potential biochemical defect, or should we go for an exome? They've already gone through 2 tests, so they decide to do a trio short read exome, which was performed at the University of Washington. And what we found there was we have, so it's the proband sample on top and then the 2 parents on the bottom. And so we have this de novo in-frame deletion within the UBE3A gene. And what short read sequencing couldn't tell us is whether or not it was on the maternal or paternally derived chromosome 15, but based on this individual's clinical presentation, it was consistent with a diagnosis of Angelman syndrome. So as I just told you, with that example, the process for testing individuals with imprinting disorder can involve multiple tests. So our question was, can we use long-read sequencing to simplify that journey? And as you know, the advantage of long-read sequencing is that we can detect single nucleotide variants, small indels, and structural variants from a single data source, and we can detect methylation. This is a chromosome 11, which is important for another imprinting disorder, Beckwith-Wiedemann syndrome. And so we're showing the methylated bases in red and the unmodified in blue, and we can phase this into 2 different haplotypes, and we can do this over large segments of the genome. And so I want to show here, which is really the slide from my collaborator, Danny Miller, that sort of inspired this project, is that we can show the differences in methylation on these different haplotypes. And having all of this data together in one assay is really powerful. And so the study that I have worked on with my collaborators is using whole genome long-read sequencing from residual samples that we had in our lab of individuals with a known diagnosis of Prader Willi or Angelman syndrome, and generating reports and then reviewing those reports to see if we can take that long-read information and come up with an answer. So the samples that were included in this study included whatever I could find in our freezers from previous testing. So these were 20 cases with previous clinical testing results trying to span the known mechanisms of disease as well. And so this is an example of the reports that Miranda, who is a computational scientist in the Miller lab, put together for us. So again, very colorful. Thank you, Miranda. And I want to walk you through each section of these reports that we generated. And so this is, again, this region of chromosome 15. We have, so you can see the gray boxes are sort of highlighting these regions of segmental duplication, which correspond to the recurrent breakpoints that are part of the deletions in Angelman and Prader Willi syndrome. And so we're looking at the average read depth across the region and really sort of focused between those breakpoint regions. The next part of any of these reports is a plot of the heterozygous and homozygous SNPs across this region of chromosome 15 that we were focusing on. We can also zoom out and look at all of chromosome 15, as well as the mean methylation frequency at different CpG islands within this region of chromosome 15. So you have a control or a reference on the left, and then the test sample in red. So this is the mean methylation frequency of the CpGs within that particular island. And for the rest of the talk, I'm really just going to zoom in on this Snurf-Sturpen island, which is the critical one in Prader Willi and Angelman syndrome. Okay, so here's an example. I'll take you through it. So we're looking across the read depth that does not suggest the presence of a copy number variant. We have both heterozygous and homozygous SNPs. The methylation pattern in red looks like the reference in gray. So this would be an example of a negative result. Okay, and there we go. All right, so in this next sample, hopefully you can appreciate there's a lower read depth between BP2 and the BP3 region. We have absence of heterozygous SNPs within that same region, and the methylation compared to the reference is reduced. So here, if we integrate that information, it would be consistent with Angelman syndrome due to a deletion of maternal chromosome 15. Again, this is from a clinical sample that we received in a lab. This was a 5-year-old female who was having seizures and developmental delay. Testing in our lab, the first test that was ordered was a chromosomal microarray, which showed that deletion, but it didn't tell us what chromosome that deletion involved. So we had to do a second test, which was the MS-MLPA assay, which showed us it was the maternal chromosome 15, consistent with Angelman syndrome. All right. Next example, top part, we're seeing that decrease in read depth across the BP2 to BP3 region again. Again, the absence of heterozygous SNPs, but now the methylation is increased. So here, this is consistent with Prader Willi syndrome due to a deletion of the paternal chromosome 15. This is a sample that we received from a 3-day-old female with hypotonia. Here, it only took that one test, and we were able to deliver the results to the family quite quickly, consistent with the paternal deletion and then the due to the paternal copy. All right. Okay, one more example here. So no decrease in read depth. But now we have the absence of heterozygous SNPs. So 2 copies in this region, but no heterozygous SNPs. And decreased methylation and red. So here what we're thinking about is, this indicates is paternal isodisomy. So 2 copies of the paternal chromosome 15 in Angelman syndrome. And again, we first received a sample within the lab for testing where we did detect isodisomy for the entire chromosome 15. So we're showing you copy number with the chromosomal microarray on the left, and then this purple bar and the absence of that central track is consistent with 2 completely identical copies of chromosome 15. Again, we don't know if it's the maternal or paternal copy from that chromosomal microarray, so we have to go do that second assay to determine that it was the paternal chromosome consistent with Angelman syndrome. All right, one more example. This is in this sample, we do not see a decrease in the read depth. We do see heterozygous SNPs. The methylation pattern is not grossly different than normal. But now if we look within the UBE3A gene in 2 different haplotypes, we see a 3 base pair deletion in haplotype 2, and we can actually use the methylation information to phase this and to determine that this was a variant on the maternal chromosome 15 within that UBE3A gene consistent with Angelman syndrome. So this is the patient that I told you about at the beginning, where we needed 3 separate tests that were performed over a course of 15 months to provide an answer for this family. So overall, just wanted to summarize, showing that these reports were reviewed by 3 different people who were blinded to any clinical information, the results of previous testing, didn't provide them with any hints of like, oh, this is from a 2-year-old or a 2-day-old with hypotonia. But they did great. So for all of the first 20 samples that they took a look at these reports, they arrived at the result that was consistent with the previous molecular testing. And so, I think that this illustrates that there's a potential there for long-read sequencing that could help simplify that diagnostic odyssey for patients with imprinting disorders. I think it was really challenging for that family to get to talk to their doctor about the potential for Angelman syndrome and think, yeah, that makes sense with my kid, and then getting my report that says negative with the fine print of, well, we can't detect all causes. So I think that was really challenging. So one of the things that we're really excited about is the potential to use long-read sequencing to shorten that process. And so some of the next steps we're thinking about is, there's other different 15q abnormalities that we could use the same data to look for. Again, I'm not going to walk you through this very complex tree on the right, but this is the testing algorithm for Beckwith-Wiedemann syndrome. It's not a test that we've brought on in my lab because it's even more challenging than some of the Prader Willi and Angelman syndrome testing that we do. But I think there's huge potential there for the long-read data with the integration of methylation calling. So with that, I would just like to thank my collaborators on this project, specifically Danny, Anita, and Maddie, who did a lot of that analysis of those blinded reports, and especially Jaya and Beto from my lab, who dug through the freezers to find some of these samples that we can include in the study, as well as our financial support. And with that, I will end and happy to take any questions. Thank you.